First of all, let me say my apologies for not being there. I had every intention to do so. I've been vaccinated 4 times, and the COVID bug caught me a short while ago. So I get to finally use the excuse of COVID brain. If I say something that doesn't make sense to you, that's probably why. But I'm doing better. I wanted to say this is a tremendous opportunity. I'm very honored to be here today to talk to you about liver-directed drugs in the pipeline. I have had a little internet issue, so if I glitch out, just bear with me. I should come back up. But I wanted to say you can't keep a good Texan down, and in following on with Naeem and Ken Kuzi's talk, it reminds me of a quote from David Farragut, who is the first U.S. Navy admiral, who said, "Damn the torpedoes, full speed ahead." And that was in a battle in the Gulf of Mexico, where all of his colleagues were hesitating to move in on the Mobile Bay because of mines that were in the water. And he took the bold, decisive decision to take the lead and forge ahead in battle. And that's exactly what Ken Kuzi is doing from the endocrinology perspective. So I have a lot of respect for Ken, and I just wanted to say shout out to him for all the work he's done in the endocrinology field to really kind of bring us together as a hepatoendocrinologist. So thank you, Ken. And then to my good friend Naeem, I love the pyramid, and in your honor, I'm going to go get some good South Texas barbecue today. So with that, let me forge ahead. These are my disclosures. So my objectives are really to focus in, to drill down on the liver. You've heard Naeem and Ken talk about extrahepatic benefits of treating patients. I'm going to focus now really on the liver, and we're going to talk about our current endpoint assessment and the rationale, drugs in late stage development, a little bit on combination therapy. I'll give another shout out to Naeem at that point, and then some future considerations. So this is our current FDA registrational histological endpoint. You have to hit one or both of these, either NASH resolution without worsening of fibrosis, or fibrosis improvement of at least one stage with no worsening of NASH. And using an iceberg as an example, one of the main targets of our drug therapy is histopathologic. And why is that? Because we know that NASH can progress to a clinical outcome. Here's the problem. It takes years in most patients to reach that. So if we're going to develop a drug, we don't want to dissuade or discourage our pharma colleagues from wading into the field of NASH drug development. And so we have been offered the opportunity by the regulatory authorities to have a surrogate outcome, which ties to an outcome. And so that's what I want to spend a brief moment on, is linking how we know that fibrosis and NASH links to an outcome. And here's one of 5 meta-analyses that have been done, linking hazard ratios for different stages of fibrosis to both severe liver disease and liver-related mortality. And you see really at F2 or greater on the right, liver-related mortality, we see a hazard ratio that puts patients at greater risk. And thus, that's why we study F2 or greater patients in clinical trials. Now, what is the evidence that regression of NASH cirrhosis is associated with improved outcome? Because intuitively, you have to make the jump that if we're going to treat people and we're going to improve liver disease, that actually improves an outcome. And here's some recent data that we published in Hepatology last year, showing that improvement in NASH fibrosis stage was in fact associated with a lower risk of liver-related events. Furthermore, we know from the bariatric surgery literature that if you improve NASH, you actually also have improvements in fibrosis. Here we see a very elegant study published in Gastro in 2020, where 84% of patients at 5 years had NASH resolution, and this corresponded to 70% of patients having improvement in fibrosis. Now, taking that a bit further and drilling down on this French single center bariatric surgery study in 180 patients, we see two graphs here. On the left in maroon, we see as you lose more and more body weight as defined by BMI loss, you have more resolution of NASH. On the right, we see a correspondingly greater increase in F0 and F1 patients going from baseline to year 5. Now, looking at some more recent data published by Dave Kleiner and colleagues in JAMA, what I direct your attention to first is the line graph on the left, where you have on the x-axis fibrosis stage and on the y-axis change in the NAFLD activity score. And what you can simply see is as you improve the NAFLD activity score, you tend to get improvement in fibrosis, and vice versa. As you worsen NAFLD activity score, we tend to get worsening in fibrosis stage. And on the right, we see a graph that illustrates something very, very similar. The first bar is the first biopsy showing NASH and its corresponding underlying fibrosis stage. And if we look to the right, the last biopsy showing only NAFLD, no longer NASH, we see more and more F0 and F1 disease. And here is just some recent, not recent actually, it's actually relatively old data coming from elafibranor in the phase 2b Golden 505 trial. But this concept is the same, and this is looking at change in ballooning and inflammation on the y-axis on the graph on the left, where you see if you look at fibrosis, either improvers or worseners, red would be the improvers. As you improve ballooning and inflammation, you improve fibrosis, and vicariously as you worsen ballooning and inflammation, there tended to be worsening in fibrosis. Now, it's important to stay focused, but let's not lose sight of what we're really trying to get after here. And that is additional components, as mentioned by Naeem and Ken and others, lipotoxic fat, weight loss, atherogenic lipid improvement, and glycemic control. And if we use this as an iceberg to depict all the things we want to improve with our drug therapy, the question is single therapy enough, or will we need multi-modality treatment? Well, I think you can see from this figure that Monica Connerman and I published a little while ago, there is a huge number of pathways that lead to what we see histopathologically as NASH and can progress to cirrhosis and decompensation. Now, this is both a benefit and a curse. The benefit is we have lots of different targets we can go after. The curse is that oftentimes targeting one simple pathway, the liver is redundant in its mechanism of activating downstream modulators, and we're often left short-handed. So what we've learned along the way is targeting drugs that act further upstream tend to have more pleiotropic effects downstream. And Ken talked a lot about this, where he mentioned getting after lipotoxic fat by improving adipose tissue health, reducing insulin resistance, free fatty acid flux into the liver. But there's additional therapies we can go after as well, which would be blocking de novo lipogenesis, and we see multiple different mechanisms for that. We can improve beta oxidation, and quite frankly, we can improve mitochondrial health. And by improving mitochondrial health, we reduce endoplasmic reticulum stress, the unfolded protein response, and all the downstream activators that ultimately result in stellate cell activation. Unfortunately, drugs that have specifically targeted anti-inflammatory mechanisms and anti-fibrotic mechanisms have tended to be less dynamic and have not made it across the finish line, or at least not made it as far along in development as drugs that have really targeted the metabolic pathways. So really what we've seen in drug development in NASH is a tendency to target metabolic derangements through the mechanisms you see listed here. And I want to spend a little bit more time on that. Now, it's a complicated field, but what I've tried to do is to break down drugs in early phase 2A development, focusing on non-invasive endpoints. These are short duration trials, really just trying to get after some safety information and early evidence of efficacy. And on the left, you see lots of different drugs, from FXR agonist to mixed growth hormone receptor agonist, mineralocorticoid agonist, FGF21s, GLP-1s, galectin inhibitors. On the right, we see drugs that have made it into phase 2B. So the good news is you see more of them. There's a lot of drugs currently in development looking at very large paired liver biopsy studies targeting histopathology as an endpoint. So that's the good news. Further to this, you can break these agents down into oral agents and injectable agents or infusions. As a general rule, hormones are going to be injectables. So the FGF19s, the FGF21s, and then most of our GLP-1 RAs and combination GLP-1 receptor agonists with GIPs like tirzepatide that has been spoken about already, or other drugs like a GLP-1 glucagon agonist, catutitide, or even Altimmune's new drug as well are injectable. On the left, we see a ton of oral agents that are in development, and this is good news. And I think ultimately there will be opportunities to combine these to get after the multiple different mechanisms that I alluded to 2 slides ago. But let me just keep going for the purposes of time and show you what's in phase 3. So right now there are 5 drugs in phase 3 development targeting NASH and its fibrosis. We have 4 oral agents and 1 injectable. Semaglutide is currently enrolling a registration phase 3 trial, and that's the injectable on the right. Although, as Ken mentioned, there are oral semaglutide. It's not currently being studied in NASH, at least at this stage. On the oral agents, the obeticholic acid drug has achieved its phase 3 registrational endpoint. However, on filing of its new drug application for NASH, it was not approved. Now, it doesn't mean the drug is dead. It is currently still being developed. The phase 3 trial is ongoing, and there is hope that they will potentially refile this year. Lanifibranor is currently enrolling a very large phase 3 registration trial. Resmetirom has 2 phase 3 trials. One is completed, and I'll be mentioning the top line data at FAASLD this year. And then the registration trial is in the public domain, is being read out in Q3 of this year. So we will hopefully know before the end of this year if resmetirom is likely to have achieved what it needs to achieve to file a new drug application. And then a RAM call to round out the phase 3s is currently on hold. Now, what about NASH cirrhosis studies? Well, there are 5 currently and several more soon to be added. There is 1 phase 3 with obeticholic acid. It is, we are all anxiously awaiting the results of this trial. The study is concluded. The data is being mined right now for the top line results. Belapectin is a galectin-3 inhibitor. This is an infusion given every 2 weeks, and it is currently recruiting over 1,000 patients. Aldafermin has completed enrollment in a phase 2 trial in 150 patients. This is the FGF19 analog. It's a 1-year trial, and we're hopeful that this drug will show positive impacts on histopathology in the setting of NASH cirrhosis. Efruxifermin is an FGF21 analog. It is currently actively recruiting about 200 patients in a well-compensated F4 study. And then we also have a combination trial with semaglutide, selifexor, and firsocostat, actively recruiting over 400 patients right now. So just to give you perspective, the future of trials and where they are, the Aramcol drug is currently on hold. Resmetirom, the Part 1 surrogate endpoint registrational trial readout is anticipated in Q3 of this year, with long-term outcomes to March 2024. Obeticholic acid is forging ahead with its outcome trial, and we should have results in September 2025. Semaglutide enrolling currently with an anticipated surrogate endpoint assessment in April 2024. And then lanifibranor enrolling as well, with anticipated readouts in February or Q1 of 2024. Now, we've not been without our failures. There have been many drugs that we've tried in NASH and have gone to the graveyard. But to quote another Navy Admiral, Admiral William McRaven, know that life is not fair and that you will fail often. But if you take some risk, the generations that follow will live in a world far better than the one we have today. So we're not afraid of failure. We're afraid of regret. And so we're going to take lessons learned from failure and apply it to future therapy. And that's taking our drugs from the Wright brothers stage on the left, which is where we currently are, and driving them to the fifth generation strike fighter you see on the right, which is precision laser guided therapy for NASH. What is our ideal combination? And I really think this is the future. It's not going to be monotherapy. It's going to be multimodality therapy. Ideally, what we would love to have in our asymptomatic patients with moderate to severe disease is an oral, well-tolerated and safe therapy that's synergistic. It improves histology. It improves extrahepatic metabolic profiles. It enhances long-term outcomes and reduces malo and MACE, as Naeem has mentioned. So I take this from Mike Charlton, a great friend and colleague who uses the Jamaican 4x100 meter relay world record set in Seoul as an example. All of the 4 sprinters you see are world-class in their own right. They get along well with each other, and they all had complementary strengths with similar endurance, and they came from the same general home. And when we think about drug development in combination therapy, that's exactly what we want. We want drugs that are effective in their own right and that they play well with others in the sandbox. They don't have drug-drug interactions. And they complement each other, whether that's complementary actions on histopathology, or maybe one drug doesn't have much effect on glycemic control, but it does have effects on lipids. Combining it with a drug that has effects on glycemic control and synergistically enhances the histopathologic benefit would be great. They also endure. They don't develop drug-drug antibodies or anti-drug antibodies. They don't develop tolerance, and they're able to remain effective over the long haul. So here's our therapeutic actions by mechanism, and I have many listed here. I don't have time to go through them in detail, but I do think there's opportunity for combinations. If we just look under inflammation, cholesterol, toxicity, multifunctional, we could pick a PPAR agonist like lanifibranor. It's actually a pan-PPAR, PPAR alpha and delta activity as well. We could combine that potentially with a thyroid hormone receptor beta agonist. When you do that, you synergize the lipids, you potentially synergize histopathology. But resmetirom or thyroid hormone receptor beta drugs do not impact weight, and they do not impact glycemic control. Adding lanifibranor to the mix, we would also potentially gain benefit from glycemic control. We still would have a problem with weight, not having weight loss, but potentially there are other combinations that would work as well. You could also combine an injectable with an oral, or another alternative might be to use induction therapy with an IV or injectable therapy, get the disease under control, and then switch to an oral agent for the long term. Here's an example of a combination therapeutic regimen that Naeem Al-Khoury and colleagues have recently published. This looks at semaglutide, which is a GLP-1 receptor agonist, farsocostat, which is an acetyl-CoA carboxylase inhibitor, and selexor, an FXR agonist. This gets out after exactly what I was talking about earlier, getting after multimodality therapy. We're blocking bile acid synthesis, we're blocking de novo lipogenesis, and we're improving adipocyte health and reducing free fatty acid flux into the liver. This is the trial design. 108 patients randomized to 5 different cohorts. The last cohort, 21 patients, is sema, farsocostat, and selexor, so the triple combination therapy. And these patients were randomized equally in a 1-to-1 to 1-to-1 to 1 distribution scheme. And you could get in using histopathology equaling F2 or F3 NASH cirrhosis, or you could get in non-invasively if you met the parameters you see listed here. What's important to see in this slide is that there were greater improvements in ALT, AST, and CK18 with combination therapy. And I just highlight ALT here at the top. There were significantly greater reductions in ALT in all combination groups versus semaglutide alone. Now, when we look at ELF scores, didn't seem to be that big of a difference in combination therapy. Again, what we know is what was elegantly explained by Ken Kuzi. Sema, while it didn't hit statistical significance on fibrosis in monotherapy, it was shown to reduce progression of disease. And we don't really talk about that in this slide or in any slides as much as we probably should. Now, what about looking at liver stiffness by FibroScan or VCTE? Across the board, there were similar reductions in liver stiffness between groups and no difference in changes in liver stiffness by MR elastography. But when we look at FAST score, which is a combination of FibroScan plus AST, we see that all combinations, with the exception of the FXR ACC inhibitor, led to significantly greater improvement in FAST score versus SEMA alone. So I want to briefly talk about the future, this precision medicine concept that I highlighted early. And what I'd like to show is that there are ways that we're working towards that we can really get after fibrosis directly using therapeutic oligonucleotides. We see an example of that with the DGAT inhibitor that's currently in development as an antisense oligonucleotide. We can target the microbiome. We don't have time to get into that today, but certainly there's some overlap and integration between the microbiome and underlying histopathology. And then finally, targeting these two significant genetic polymorphisms, HSD17 beta 13 and PNPLA3, we may be able to augment or accentuate the benefits of drug therapy by targeting these particular polymorphisms. So in summary, as our understanding of NASH pathogenesis improves, the number of targets in NASH drug development definitely is expanding. We're targeting both histopathology and dysregulated metabolism. The purpose of my talk today was really to focus on the histopathology piece, but we can't leave out the cardiometabolic benefits of drugs as well as renal benefits, driving towards MALO and MACE outcomes. And
so we just lost the connection with Stephen. I think we all have the key message.